Good afternoon, everyone. Thank you for the opportunity. I am Dr. Neelam Harsha, resident of Neonatology from Niloufer Hospital, a tertiary care center located in Hyderabad, Telangana. This is done under the guidance of Professor and HOD, Dr. Swapna ma'am. The study is comparison of predictive ability of Hammersmith Neonatal Neurological examination. Neonatal neurological examination. In the instruction, we have the major issue is prematurity. Survival of many very preterm and extremely premature infants have increased since the 1960s because of the availability of advanced neonatal intensive care, advances in technology, expanded access to the life-saving equipment.
Excuse me, ma'am. Sorry for the interruption. Can you open your PPT?
I'm sharing it, sir.
No, it is not. It is not visible.
Is it visible now, sir?
Yeah, you can continue, ma'am.
So with this, prematurity being a high-risk group, because of the increased rates of survival, they're often prone to long-term neurological and health problems. For this, neurological examination imaging may be useful to prognosticate. However, imaging is still a difficult and inaccessible task for many of the centers. Thus, a comprehensive neurological examination is mandatory. HNNE, which is a comprehensive neurological examination done in the neonates, is performed around 2 weeks of age in term neonates, and its estimated term age in preterm neonates has the best in terms of accuracy in predicting neurodevelopmental disability. However, in resource-limited settings, preterms as well as high-risk terms are often discharged before they reach this recommended age for HNNE. Thus, performing the HNNE before the recommended age and before the discharge itself is a beneficial strategy. Making this as a study point and the rationale of our study, and also because most of the studies done in this context are from the Western population, and these have there are longitudinal studies which have correlated HNNE scores with Bailey examination 12 months of chronological age. We have proposed in our study to correlate our HNNE findings performed early versus term equivalent age with HINE findings done at 6 months of chronological age. We have proposed to perform early HNNE at 34 weeks, which can be cut-off age for the discharge in SNC's facilities, especially in India. Thus, the aims and objectives of this study are to evaluate the diagnostic accuracy of early Hammersmith neonatal neurological examination at 34 weeks in comparison to the regular examination at term equivalent age with neurological assessment at 6 months of age using the Hammersmith infantile neurological examination, which accounts to 3 to 4 months of corrected age. The methodology is a prospective observational study with preterm neonates between 28 to 32 weeks admitted in level 3 of Niloufer hospitals were enrolled. And they were enrolled over a period of 12 months between February 2023 to February 2024 and were followed up till August 2024. The inclusion criteria were all preterm neonates between 28 and 32 weeks will be examined at 34 weeks and term equivalent age if they are clinically stable. Families from far-off places and who are not willing to follow up and who have given refusal for any consent, or babies with major congenital malformation or chromosome anomalies, infants with birth asphyxia and grade 3 and 4 IVH, and babies who are critically sick have been excluded. The flow of study can be showed as follows. All the preterm babies who were less than 34 weeks, based on whoever were screened at Niloufer Hospital, based on inclusion and exclusion criteria, around 120 preterm babies were enrolled, and baseline HNNE was done at 34 weeks, which is performed early gestation. And following which HNNE examination at 40 weeks, that is the term equivalent age or the recommended age for of 105 preterm babies were done. Subsequently, at 6 months of chronological age, HNNE examination was done, which is around 73 babies. Based on this data, a receiver operator curve was constructed to determine the area under the curve and suitable cutoff value for HNNE optimal scores performed early and term equivalent age to predict the HNNE category was done. The results can be tabulated as follows. The number of babies who were examined at 34 weeks and at term equivalent age were 105 babies. and the babies who were examined at 6 months of age was with HNNE were 73, which accounts to 69.5% of the baseline population. The early HNNE was done at around 34.2 weeks, and term equivalent age HNNE was done at 40.5 weeks. And the total optimality score at performed early score was 21.85 plus 26.269, and term equivalent age was 29.49 plus 1.62. As we can see, there is a gradual increase in all the subcomponents of the HNNE optimality scores in when compared to the performed early age and term equivalent age. And the chronological age at which the HINE was done was 6 months, and the HINE scores were 59.18 plus 2.56 with a range of 55 to 68. Based on this, the ROC curves were made, and with a by the trade-off for sensitivity and specificity, a cutoff score of 22.5 was taken for performed early HNNE, and where the sensitivity accounts for 52% and 70%, and 29.5 cutoff score was taken for term equivalent age, and 64%, 61% was the sensitivity and specificity for term equivalent age. This shows that the area under curve of performed early and term equivalent age assessment were almost comparable. A single cutoff could not be used at both assessment points as the overlapping of values were minimal, which is understandable because of the difference of around 6 weeks of gestation between performed early and term equivalent age. This study was also on similar terms was also done in different areas, predominantly the Western countries, as already mentioned. Mercury et al. Performed that study of HNNE in preterm babies, but at term equivalent age only in the year 2003, and concluded the total optimality score of that cohort was 26.4. And Brown et al. Performed a study in 2006, and the mean gestation is 27.6, and the term optimality score was 26.6. In our study, we have taken both term and preterm babies, and the average gestational age was 29.8 plus or minus 1.46 with a range of 28 to 32 weeks, and the total optimality score was 29.4 plus or minus 1.62. This was almost incomparable to the term equivalent age optimality scores of the other studies. However, as I've told, because the babies are being discharged before the recommended age, studies have also come up to see the efficacy of HNNE if performed early. However, only one Indian study has been performed, but even that has included the term babies, that is from 28 weeks to term babies, and the performed early was almost around 34 to 40 weeks of an range, and the total optimality score was 32.5. However, it has shown that the similar diagnostic accuracy of HNNE was seen even at 36 weeks. 2 studies were done in the Western data, where performed early was done at around 30 to 32 weeks, and they have also showed that there is a moderate diagnostic accuracy. And Howard et al. In fact told that there is a stronger predictive ability of HNNE performed early. In our study, as I've already told, the mean gestation is 29.8 weeks and performed early was 34 weeks. And the performed early total optimality score was 21.85 plus or minus 2.6. And it is also concluded there is a moderate diagnostic accuracy of HNNE performed early. Differences in the gestational age, sample size, and follow-up period may contribute to the variability in these studies. Also, recent studies have also concluded that early HNNE may be as relevant as term equivalent age assessment in predicting neurodevelopmental outcomes, similar to finding in our study. Also, this emphasizes that clinicians should consider gestational age when interpreting HNNE results to ensure accurate assessment of neurological development. The strengths of my study are: it is a prospective observational study. It is done in a low middle income group country. And HNNE and HNE are simple but comprehensive studies, and early screening, that is done at 34 weeks, which is usually the discharge criteria of SNCUs, has been taken in the study. However, this study also has limitation because it has a shorter follow-up, and though HNNE is a comprehensive study, Bailey is more diagnostic. Thus, in conclusion, this study shows that the HNNE done early, that is at 34 weeks before or at discharge of the time, the baby has a moderate predictive accuracy as compared to the term equivalent age HNNE in relation to the HNNE scores of our cohort. This study also presents the longitudinal data of HNNE optimality scores of a preterm in this population. The results of this study suggest that the combination of early HNNE scores and HNE scores with other clinical and neuroimaging data will likely provide more accurate identification of those infants at greater risk of adverse neurocognitive outcomes. These are my references. Thank you. Thank you for the opportunity.